Hello, and welcome back to episode 2 of Health Without the System podcast. I'm Dr. Tim Scott, and this is my wife, Mia.
Hi, guys. Welcome back. My name is Mia Scott, and welcome back if you guys have listened to our first episode. This episode, we wanted to kind of dive into things that we see every single day in clinical setting, and that would just be the labs that are done by our patients that we are reviewing or getting done ourselves, and allow our patients to break it down and what is very important and things that we look for. So this episode is just going to be kind of going over very special and particular labs that are very common and kind of breaking them down so you guys can be a better advocate for yourself.
Yeah, I think the idea is you're going to get these annual labs from your doctor, maybe once a year or twice a year, and you're really sort of relying on your doctor to tell you what's normal and not normal. And a concept that we focus on a lot is normal in terms of a standard lab range is not always the same thing as optimal. So we'd like to run you through these common labs really quick today, point out a few things that you can look at. Obviously, you can save this for later. You can take some notes. And then next time when you get those labs, you can have a little bit more knowledge. And as we always say, knowledge is power.
Yep. And we're going to actually touch on some definitions or terms that you might hear often, but is not super common to, just like the average person not in the medical field. The first one that you'll hear us say is mitochondrial dysfunction. Well, what in the world is a mitochondria? And these are the powerhouses of your cell. They literally control your energy production, and they kind of make everything go round. And when you have mitochondria damage or impair, it's really hard for your body to, clean house and do that cellular repair and things of that nature, which could lead to significant chronic disease processes.
Yeah, sort of think of that mitochondria as like this engine within the cell, right? And it needs good fuel, and fuel can come in the things you eat in your diet, but also supplements, nutritions, minerals, vitamins. Think of things like magnesium, CoQ10, B vitamins, alpha lipoic acid, carnitine. The engine needs this fuel, and fat or sugar or toxins, other things can gunk up this engine, and they can decrease the performance of this engine. So when we talk about mitochondrial dysfunction, we're taking all these things into consideration.
Yep. And another thing with mitochondria, like Tim said here, anything inflammatory, toxic lifestyle, mold is a big one that will wreak havoc on your mitochondria. And what happens is when your mitochondria cannot function, like we said, it cannot do that cellular waste and kind of target those cells that are damaging or concerning. So you really have this array of disease processes that come about because you can no longer self-regulate some of these cells. So that's a really big one.
Yeah. The next one would be oxidative stress. And if you're thinking of the mitochondria as an engine, think of some of the exhaust that comes off of that engine as oxidative stress. Basically, it's harmful byproducts of metabolism, and their reactive free radicals are kind of what we're talking about here on the molecular level. But basically, your body can only neutralize so many of these before your system starts to get overwhelmed, and that exhaust starts to build up and then start to screw other things up, like your DNA repair, your DNA replication, and then that can lead to, again, long-term things like chronic inflammation, chronic disease, cancers.
Yep. And think of an oxidative stress as I kind of explain to my patients, like imagine your entire system as like pipes. Your vessels and et cetera are pipes. And when you have rust, that is essentially like an oxidation. So if you have a pipe that is rusted in your house, you're going to have those particles that start to break off. They can create erosions. They can have, like bumps and things in it. And that's when things go bad, when your body cannot regulate that oxidative stress. And, as we talk about every single day with our patients, food is medicine. Every single meal will either fuel or fight your disease process, including oxidative stress. You need all those antioxidants in your diet to be able to regulate your oxidative stress so they don't become these very toxic free radicals in your body.
Yeah, the thing to remember, it's not just a biochemical process, it's a modifiable factor. So this mitochondrial dysfunction, this oxidative stress, you can modify these along with the next two things we're going to talk about, which have to do with the gut. The first one being gut dysbiosis. This is pretty simply just an imbalance or disruption of your gut bacteria, the bad outweighing the good not being enough.
Sure. Yep. We have a very diverse we should have a very diverse species in our gut. And the more diverse your gut microbiome is, the more everything, functions. The better your immune system, the better your mental health, the better that your body can recognize, some of these foreign things. So if you have a diverse species, that is when you're quite literally the healthiest. But if you don't have a diverse population of gut bacteria, that's when things can start to take over. You can have an overpopulation of bad gut bacteria, and they can be linked to so many other disease processes. So understanding dysbiosis and how to correct that is very important as well.
Yeah, and the last thing when talking about the gut is a lot of times we'll mention leaky gut, and just understand that this is sort of that theory where inflammation within your gut, where certain foods where this over time, these cells that are normally very tight together start to gap apart a little bit. And when that happens, the theory is that food particles can present directly into your bloodstream and directly to the immune system, and they can lead to activation and immune responses that over time can be chronic diseases and autoimmune diseases.
And this is huge in food sensitivities. When someone has a leaky gut, like you have to imagine that you have these very tight junctions in your gut. And when those start to separate, become inflamed, irritable bowel, constipation, if you are not going daily, it's very likely that you have leaky gut. And what happens is when, like Tim said, when those food particles are leaking in, then you can actually develop an allergy or a food, not a true allergy. It's a different response, but it's a food sensitivity to some of these foods that are leaking out because now your body is recognizing them as foreign because they're not where they're supposed to be. Then you can have these triggers of immune responses. So
those are some basic definitions. I know so far everybody's loving the stats. Mia, you want to jump into a few stats and then we'll hit the lab tests?
Absolutely. So this podcast, like we said, all about labs, and 44% of necessary tests go unordered. So that means that many very important tests that your primary care should be doing, they are not doing.
An example of that is a hemoglobin A1C.
Yep.
And we'll talk more about that.
Yep. And 1 in 20 U.S. adults experience a diagnosis error yearly, and half of these errors lead to serious harm or death.
Yeah, let's look at that as just maybe you're not interpreting a TSH in your thyroid panel to the best extent. And maybe now that's another year that someone's thyroid disorder goes unnoticed or undiagnosed.
Yep. 88% of patients with autoimmune disease are misdiagnosed for years before proper testing is done. And many are first diagnosed with like the depression, anxiety, mental health issues. Of course, as we know, gut is directly connected to the brain, and those go diagnosed, and that is straight from the American Autoimmune Related Disease Association.
Yeah, and I think something there is a lot of times we're not looking at different vitamin, mineral testing, maybe even food sensitivity testing, and things are sort of getting blamed on just, fatigue, or even that wastebasket term of like fibromyalgia at times.
Yep.
It's not fair to people. If you're not doing some of these tests, you're not going to find that out.
Yep. And the last statistic here is over 70% of the immune system is in the gut, yet most doctors fail to order gut microbiome or stool tests for autoimmune patients. So this is where we were talking about, that's where you're going to pick up on that gut dysbiosis, leaky gut, missed infections, autoimmune issues that could all be stemming from your gut. Majority of your immune system lies in your gut, yet very rarely, if ever, does Western medicine ever test anything with the gut besides your obvious scoping, your endoscopy, your colonoscopy, but that's still not looking at bacteria, microbes, living organisms. It's just checking out like your vessels and your vasculature in there.
And I have a stat that I can sneaking in on you. 90% of Americans are deficient in at least one critical nutrient. How I mentioned they're involved in all those processes, yet routine nutrient testing is rarely ordered. And that's from the CDC Nutrition Report.
Yep. And like I was telling him, I beg to differ. It's even higher than that. I have yet to test for one of my patients that has been perfect. 100% of the patients that I test are deficient in at least something, if not 15 to 20 micronutrients.
And because we don't really come to this one later, some of the big ones, if you're taking notes, anything just to remember today, magnesium, vitamin D, zinc, and B12 are all huge. And if you can get your doctor to check an omega-3 to omega-6 ratio, that's another big one. Omega-3s are big for those phospholipid membranes and overall that reduced inflammatory and cardiovascular risk.
And if you're doing an omega, make sure it's a very good source. Make sure it's tested. Those can oxidize, like the fish oils, those can oxidize very easily and become rancid. So
and we'll probably talk about that in the later episodes. Yep. Okay, let's dive into the lab tests. So we're going to go over a few of the very common lab tests this year that you will probably see in your results. And feel free to look back, grab a couple years of your data off of your MyChart or whatever it's called in your area and pull up some of these tests and look through what we're talking about.
So the first one is going to be a complete blood count. This is typically, we like it with differential. It's one of the most commonly ordered labs. We're going to kind of skim through this one, but there is some things. And remember, just because it's normal doesn't mean that it's your functional or your optimal level. And it's very important that your providers are monitoring trends over time, because as things are starting to shift, if they are, those are things, especially if you're symptomatic or even if you're asymptomatic, it can lead you to like, what could this potentially become? So for instance, the red blood cells and the hemoglobin hematocrit, they are insight to oxygen, nutrient status. It can also mean like low B12, low folic acid
iron.
Levels. Yep. So
Exactly.
Things that are very important for oxygenation of our body. Of course, we need oxygen.
Yeah. And I get a lot of people that ask me when they see an abnormal about the MCV. If you see the MCV, that's basically like the volume of the cell on there. That's something, if it's real low over time, it might be able to point you towards like chronic inflammation or even heavy metals. Again, that's not a one-time test. We're talking trends. We're talking you have dysfunction, things that haven't been diagnosed. This is a way to look deeper.
Yep, same thing with the platelets and the red blood cell count. Of course, that's going to be immunity and kind of monitoring those trends to see if your body is under fire with anything immune that is going on. So chronic infections, gut permeability is another one too. It can kind of assess if you do have that leaky gut character. Of course, there's many more biomarkers to do with that one, but just looking at some of those trends.
Yeah, you said red blood cells, but you meant white
blood cells. Yep.
Platelets and
Platelets
white blood cells. White blood cell system is associated with immunity. And another thing, for example, with that is eosinophils. When you're on that differential, that can actually kind of point you towards parasitic infections. I know you look at that one a lot.
Yep, eosinophils and monocytes. So typically, and once again, this is also going to be like a symptomatic patient. Anybody who has like bloating or dark circles under their eyes, grinding teeth, can't stay asleep, fall asleep, and they have an elevated, and when I say elevated, I mean it's still going to be within range, but we typically say the eosinophils over 3 and the monocytes over 6 or 7. With that story, those could absolutely indicate a parasitic infection.
Thank you.
Way more common than you think.
Agreed. And, just for our audience, we will come back to these later, and especially with requests, we can do much further deep dives. We're really trying to keep it a little bit more surface level today. We want to make it easy for you to understand, and we want you to have some actionable items where you can look at your own blood work and talk to your doctor about this. The next one is hugely important, thyroid markers.
Yep. Up to 75% of thyroid disease goes undiagnosed for a very long time. And this is just due to the fact that many providers are only testing for your TSH or your thyroid stimulating hormone. I get this all the time in my patients. They come to me and they are like the walking thyroid story. They say difficulty losing weight, brittle nails, thinning hair, skin dry, like all of the things that you're like thyroid. And they said, no, my primary care ran the thyroid levels. It's fine. And then I will always say, well, what did they run? And it's just a TSH. That gives you nothing of value, I guess I would say. It's just a sensor in your pituitary gland. It's not even in your thyroid. And it just senses how much TSH is circulating in your body. It gives nothing on how your body is absorbing, how it's utilizing the thyroid, the hormones, or if you're even producing antibodies to attack that. So a lot of times you'll have someone who has a normal thyroid stimulating hormone because that could be one of the last markers to go faulty. And then if you do an entire panel, that's where you can see trends or antibodies that you're going to be in a big thyroid crisis if you keep, continuing. And a lot of times it's too late for a patient, not too late. A lot of times it's too far gone for patients that are,
you might have some permanent damage.
Correct.
The other thing is also the range. So in traditional Western medicine, the range of TSH for being normal is 0.3 to 3. But in functional and integrative medicine, we're really using a range of more like 1 to 2. So again, this is where normal is not necessarily optimal. And if I have someone who comes to me with some of the symptoms Mia suggested and their TSH is 2.8, I'm going to look at that and say, hey, we need to look deeper. Whereas in traditional Western medicine, you might have been told, oh, this is within normal. Let's look elsewhere. And that's why some of these can go undiagnosed over so many years.
Yeah, so I'll kind of rattle off the entire panel that I would get. And this is just for any female in general who might have the smallest idea that you could potentially have a thyroid issue. And the list is very long. However, it is very important to get the entire snapshot of your thyroid to make sure that you're doing the conversions correctly, absorbing, utilizing, etc. So what to order? Of course, the TSH. It's still important, but not just that. So TSH, T3, T4, reverse T3 and T4, the T3 uptake, TPO, and TG antibodies. I also like to throw in a ferritin because this can actually impair your T3 conversion, and then vitamin D. I feel like everybody should be getting vitamin D in general, but especially for thyroid too. That is a really good one to use. So for example, like your T3 under 100 or your free T3 under 3, those are like points to conversion issues. Once again, we're getting a little bit more medical, but those are just things to look at to say that a TSH is not your end all be all. And just because that is fine does not mean that everything I just mentioned was fine. You need certain ratios for your body to function to your normal. And if you feel like something is off and you're just getting a TSH done, please advocate for yourself.
Yes, and she did rattle those off fast. Feel free to play it back in extra slow speed, which might be more of like normal human speech speed. But also, we are going to include a chart in the show notes. I'll mention it again later, but we'll make sure that we have some information for you. Let's move on. Time is limited. Let's talk about the complete metabolic panel. I feel like this is a very under-recognized test, meaning we get it all the time, but myself included up until a couple of years ago, I paid very little attention to a lot of the markers on it. I think today we're going to go over just a couple things that are really important on it. Why don't you talk about the fasting glucose?
Yeah, so that's actually probably one of my favorite ones to look at because there's once again where you call like within range, and then there's optimal range that is your body's kind of like waving a red flag here. So in Western medicine, anything that is under 99 would still be considered normal. However, in functional medicine, once it gets above about 85, we are already kind of like, tooting the horn saying, listen, we should be looking at other markers because you can actually have a normal fasting glucose and an elevated A1C and an elevated insulin level, and this is all telling you that something else can be going on. Just to give an example, because it's fresh off my mind, this just happened yesterday. One of my patients, I looked at her labs that her primary care did, and oddly enough, her primary care did get a fasting insulin, which is very shocking, but she did not get an A1C. Her glucose was 98 fasting, which would be considered normal. Primary care says everything is fine. Her fasting insulin was elevated, which I told her, like, your fasting insulin is going to be pumping out to get that glucose into the cells. And if you're not testing for that, your fasting glucose will remain normal until your body cannot compensate anymore.
And the important part of that is over time, even though your body is compensating and you are pumping out extra insulin, you're actually still experiencing damage from this hyperglycemia. You are developing mitochondrial dysfunction. You are developing oxidative stress. You are trending towards type 2 diabetes. And it's only going to be a matter of time before your body can't compensate anymore and these effects hit, they blast.
Yeah, and the reason this is so important is because insulin resistance is quite literally at the base of so many disease processes, and is so important to understand your insulin resistant risk factor because just these basic labs are not going to catch that. You need a little bit more, like the fasting insulin, the A1C, CRP level, things that are kind of like hinting that you're having some metabolic issues. And you would have never been able to convince me back in school that you could have a normal fasting glucose but an elevated A1C. And in fact, I do see it. Why? Because even if your fasting glucose is normal, your blood sugar can still be spiking too high after each meals, and this can cause a dysregulation. So your fasting glucose might look normal. And when I say normal, you could still be in that 95 to 100 range where Western medicine
Not
would
optimal,
say
just
nothing
normal.
else is needed. But when you dive a little bit deeper, you may even be pre-diabetic or diabetic already. And those are major labs that we definitely should be asking for all of our patients, and even at a younger age. I get that all the time from primary care. It's not standard of care. It's a 25-year-old or whatever. We're seeing it younger and younger and younger.
Yeah, I think the point is if you have a fasting glucose above 85, please ask your primary doctor for the next time you order labs to get an A1C. And like Mia said, don't let them tell you that that's not necessary or not a part of standard of care. It's a very easy, cheap test. There's no reason insurance shouldn't cover it. And it's a very simple add-on. And we'll talk about that A1C in a minute.
That's where I add, if you don't like your doctor, find a new one.
Yeah, if they're not listening to you, it might be time to move on. Okay, there's another really important part of it. We'll be a little bit quicker with this, but the AST and ALT, which speak a little bit to your liver function. Now, your liver is sort of your quarterback for metabolism in your body. There's a lot of different things happening with triglyceride transport, cholesterol transport, storage, and even glucose. Your liver is an insight into your metabolic function. And when these enzymes are starting to elevate, they might not get above normal, but they might be out of optimal range. Again, this is a red flag. This is a warning sign to you that you are experiencing mitochondrial dysfunction, oxidative stress, fat buildup, sugar buildup within these liver cells, and we need to look at it. So the examples, the AST and ALT, even a very mild elevation, Mia has a stat on that even a very mild elevation of those can trigger as much as 50% liver dysfunction, meaning your liver functioning at 50% of its standard capacity.
Yeah, and that organ is extremely important. That is another thing that drives me insane when I get my patients that have already come with labs and they say, I have elevated liver enzymes. My primary care says it's been like this for years. There's nothing to be concerned about. Your liver is your detoxifying organ, and if that is not functioning properly, imagine the backup on a systemic systems that is going to have. I mean, it is responsible for getting rid of, your toxins, your, poisons of the body, shuttling around cholesterol. It does so much for your body. And if that is working in overdrive or not as productive, that is going to have a systemic effect. Your body is a whole system, and when you have an organ that does so much that is compensating, you're going to have stuff go wrong.
Yeah, think of, when the exit's blocked on the freeway, how much that screws up the entire freeway. And that's what's going on with the liver. And oftentimes oftentimes when you're doing a thyroid protocol, like to clean up thyroid, to help improve hormones, liver function, kidney function, oftentimes you start with a liver cleanse. And the reason for that is because of all the work it does to help clear toxins. I'm going to gloss over the kidneys today. We have other things we want to talk about, but let's just keep in mind that this is the same kind of thing as the liver. It doesn't quite do as much from the metabolic standpoint, but it's heavily involved in electrolytes, in your renin-angiotensin aldosterone system, your cortisol balance. So the kidneys are definitely very important. Monitor for trends in elevation of your BUN and your creatinine, but we're not going to dive too deep into that today.
Nope, just stay hydrated and use filtered water. Don't use tap water. Don't use bottled water. Take care of your kidneys and all the other organs that follow.
Filtered
that'll
water,
be an entire other podcast in
filtered
itself.
water in glass or stainless steel, right?
Yep.
And we'll say this again later, but ewg.org is a good place you can go and look at your local tap water to see all the contaminants inside of it.
Yeah.
The next blood test is the hemoglobin A1C. Do you want to just explain real quick what this measures? Do you want me to talk about it?
Yeah, it's just a snapshot of the last 3 months of what your glucose has been doing in your body. And this is one of the tests that always make me laugh on patients because they'll be like, oh, I had some extra sweets the last few days. And it's like, no, you can't really fake that. It's within the last 3 months. So basically these glucose molecules, they'll attach to your red blood cells. Your red blood cells have I almost said shelf life, the life of about 3 months. So that is where you can see that 3-month snapshot of what is actually going on an average every single day with your blood sugars.
Yeah. So the way I look at it is, pretend this is a red blood cell and pretend each one of these spikes on it is glucose. If you've only got one glucose spike, I know that overall you don't have a lot of glucose in your bloodstream. If you've got 5 glucose spikes, your hemoglobin A1C is high, and that tells us that over time you are having a lot of glucose in your bloodstream. You can dive into the weeds a little bit here, and like Mia mentioned, there's something called a postprandial glucose spike. So when you eat a meal, you get a big jump of glucose in your bloodstream. When that comes back down to normal, that's what causes that fatigue or tired feeling after a big or a carb heavy meal and makes you want to take a nap. Controlling that, having smaller postprandial spikes, smaller changes from the baseline, that's going to improve your hemoglobin A1C. That's also going to make you feel better and reduce all of those risks of glucose in your bloodstream.
Yeah, and I don't think one test that we didn't have listed in here that we wanted to talk about as well that is so very important is your fasting insulin. That is going to pair really well with your hemoglobin A1C. Once again, we're looking at underlying insulin resistance because that will quite literally drive so many disease processes in your body. And why are we advocating for these labs that aren't not so necessarily rare, but it's because it can give you an essential timeline of when you can actually be diagnosed with things. And it's crazy. Once again, this will probably be another podcast, but insurance actually uses tests like these to understand like what plans and programs and patients or clients that they want to take on, because they can predict down to the month and day when someone might need an intervention like a hip replacement, et cetera. So these tests are very important. Why we don't do these on a normal basis in primary care, but nonetheless, your fasting insulin, that is one test that can test to see if you're going to be pre-diabetic or diabetic up to about 10 years prior to that diagnosis.
Yeah, the fasting insulin coupled with an A1C can help you diagnose that earlier.
Yep.
Save some of that thunder because we're definitely gonna do a whole entire podcast on insulin.
Yep.
So we'll come back to that. But she's right. If you're getting an A1C, ask if they can add on a fasting insulin. If not, at least get the A1C.
Yep.
The other big one that I really want to make sure we can talk about today is the fasting lipid panel. Once you're over the age of 25, your doctor's probably ordering these every 5 years and maybe even as much as every 1 or 2 years as you get a little bit older. There is a lot of information that can be gathered from the fasting lipid panel, especially when you start pairing this with some of the other tests that we talked about. The first thing I want to say about it is, something that Mia talks about a lot is just remembering that cholesterol is not bad. Whenever you're looking at this, whenever you're looking at labs, you always have to take into context the entire patient. Are there a lot of inflammatory markers in this patient? Are there a lot of risks for cardiovascular disease? Are you essentially a fire burning, waiting to burn down the trees of your body, right? And so cholesterol is not bad. We need it for hormones, vitamin D, immune system function. We need cholesterol.
Yeah, this is something I just had a conversation with one of my patients yesterday. She's about my age. Her primary care was very concerned. She had an elevated LDL, and she wanted to dive a little bit deeper on her metabolic status. So we got some labs done, and she is not something that I'm concerned about. Why? Because everything else is great. And I'm just going to rattle off some. Her CRP, which is the inflammation of your body in general, was like non-detectable. So amazing there. Her homocysteine level, she wasn't diabetic, pre-diabetic, fasting insulin, everything was great. So she is not a big concern because cholesterol is so very important. We did some things to maybe kind of support her liver if it's like a shuttling problem, or maybe she's having a little bit of like a overload on the liver, but even liver enzymes were great. So for instance, that patient, I am not that concerned about at all. We need cholesterol, great for women's hormones, et cetera. She is not going to be a high risk versus the week prior to that. I had a guy that was about her age as well, and he was the entire metabolic disaster. Everything elevated, fatty liver. Mind you, he went to his primary care week or a month before and said, I don't feel well. She just chalked it up. He couldn't concentrate, wanted to give him Vyvanse. So you can tell how that was going to go. But anyway, he is someone that I would be concerned for because he had elevated CRP, fatty liver. He was pre-diabetic already, and his lipid panel was a disaster. Those are the patients that are going to be at high risk because you have that potential to have those cholesterol oxidize and lodge in your vascular wall and have the macrophages come and eat up and create damage. It's not the cholesterol that's the bad guy. It's they show up to the scene and they get blamed for the bad things, if that makes sense. So you really have to be looking at your entire picture because I'm a very big advocate on my patients for this. Statins don't come without risks either. And you have to understand what is, pros versus cons, whether you're going to be on a statin and potentially lower some of the cholesterol. There's a lot of evidence to kind of
You're going down the rabbit hole.
Yeah, to go back and forth with that. But you really have to look at the entire patient every single time that you're getting labs like these.
Agreed. Let's look at a few components of the fasting lipid panel. So total cholesterol by itself doesn't tell us a whole lot. You must take into account the fact that this is including LDL, HDL, and you have to look at everything else. So your HDL is traditionally considered your good cholesterol. It's basically a shuttle. It takes cholesterol out of the bloodstream, brings it back to the liver. Once it's out of the bloodstream, you're hoping that, now it's not available to deposit into the blood vessel walls and start to create damage. You want a good HDL number, and it should be about 25% of your total cholesterol as a rough estimate. It is affected by your diet. There is a genetic component, but eating, a heart healthy, high omega-3, low fat, low bad fat diet can affect your HDL. Your
Cheerios are not heart healthy, by the way.
Agreed. All right, your LDL is basically a transporter. It takes cholesterol to the tissues. And again, it's not always bad. Really, what I want you to remember from this is oxidized LDL is the bad stuff. And one of the podcasts or somebody that we listened to described that as being caramelized. Like imagine if you have a lot of sugar in your bloodstream, a lot of bad things, it sort of caramelizes things, your mitochondria, your LDL. So that oxidized LDL is what is bad. The triglycerides, this is a big one. When we look at triglycerides, we can get some major insight into your diet. It's really that blood sugar and metabolism connection. If you are eating a lot of fried foods, sugary foods, if your diet is heavily processed, your triglycerides are going to show it. So like Mia said, one way we can understand what you're eating is by your hemoglobin A1C. Another, good picture is this cholesterol panel, and specifically I'm looking at triglycerides.
Yeah, and just to add on that, when you're talking about like your healthy fats, we're talking about like grass-fed beef, wild-caught salmon, grass-fed butter, eggs. Yes, there is a
fats.
massive, debate on whether eggs are not causing your triglycerides to be 300. It is your processed food. And if you eat a clean, more natural-based diet, then nothing else is going to be, you're not going to have an elevated CRP. You're not going to have insulin resistance. Those are the things that really matter. So really staying away from those processed foods. It is not your 2 eggs in the morning that is causing your cholesterol to be through the roof. It's your packaged processed breads, bagels, or fine carb sugars.
I agree. And one thing I want you guys to look at here is this is another key area where normal is not the same as optimal. So on most of the standard labs, triglycerides of 150 or less is going to be considered normal. However, in functional medicine and the way we look at it, if your triglycerides are above 100, that's a siren. That's a red flag. You need to be looking at that. And there's a ratio that you can very easily do yourself where you take your triglyceride number and you put it on top over your HDL number. You want that number. So let's say your triglycerides are 100 and your HDL is 50, that number equals 2, right? You want that number to be you definitely want it less than 3. You would like it to be less than 2, and optimal is near 1, where your triglycerides and your HDL are almost 1-to-1. So that's something you can look at, and if you're seeing abnormalities there, you can know I need to start taking some action.
Yep, and that is a very good marker with patients that come into me and they just have like a basic cholesterol. I will do that conversion for them. Their number will be through the roof, and that is where even at home you can look at your tests because you've likely had this done. You can have your triglycerides and your HDL, divide them. If that number is, like Tim said, in the danger range, that is where you can absolutely go back to your PCP and say, I want to look at my true insulin resistant levels. So that's where the fasting insulin, things of that nature would come into play. So
yes. One last thing, because this often gets ignored, but the VLDL is also a standard on your fasting lipid panel, and it measures very low density lipoproteins. So the reason these are important is because the smaller and more dense molecules are, the easier it is for them to infiltrate your vascular lining to start to form plaques, and eventually that's going to lead to problems in the future. A VLDL number is one I want you to look at. If that's high, it's also an insight into your diet. Your triglycerides are probably high. Your liver is running out of things to do with this fat and these triglycerides, and they're putting it in things like VLDL. So again, that's telling you, you need to recognize that. You need to start to make some dietary changes. Even if the number falls at normal, I would say optimal is less than 20. So keep an eye on that.
Yeah.
I think the big thing here, cholesterol isn't the enemy. It's inflammation, it's insulin resistance, alcohol, and sugar. Those are the 4 enemies. They will screw up your lipid panel, but don't just treat the problem. The problem is not necessarily LDL. The problem is all the things that are causing your LDL to be elevated.
Yeah, and just to add one more, because I know we didn't really touch on the NMR lipid profile, but that is something that if you do ask your provider for, basically it just breaks down, like Tim said, looking at like the dense, fluffy, it kind of breaks down what your particle is actually, your particle size is actually doing. If your primary care will not run that, or it's going to be too expensive, I think it's like $50 or $75 for us to run. We also do those labs as well, but just keep that in mind. If you want to dive deeper in your actual cholesterol panel, that would be the good one to do.
Agreed. And this is a test we don't have time to talk about today, but I want to mention it. It's called a uric acid. People think of this test in terms of gout, right? You'll get it tested, but it is actually a very powerful and ignored marker of metabolic and cardiovascular health, and it can give you insights into the system processes within your body. So it's another good thing. It's very cheap. It's very easy to add on. If you're asking your doctor to get some standard panels, or maybe you saw some of these abnormalities we talked about, you can go ahead and ask them to add on a uric acid. Real quick, I want to read off, just so you guys can play this in slow motion and write it down if you want, but we will put it in the show notes. So here are some standard labs we recommend. CBC with diff, CMP, hemoglobin A1C, fasting insulin, HSCRP, GGT, lipid panel, TSH, and uric acid. Now, obviously, on some of those, if there's abnormalities, you might need some more tests, and we talked about it. For the thyroid panel, TSH, T3, T4, reverse T3, T3 uptake, TPO and TG antibodies, ferritin, and vitamin D. And if you are maybe getting a little bit older, or you have a strong family history of heart disease and you're concerned about your cardiovascular risk, here's the panel we recommend for you. CBC with diff, CMP, HSCRP, fasting insulin, ApoB, LP(a), fasting lipid panel, NMR lipid panel, homocysteine, uric acid, and vitamin D.
Sounds good. And now for our fancy legal mumbo jumbo, just a reminder that this podcast is for informational purposes only and is not medical advice. It's not a substitute for professional care, diagnosis, or treatment. Always consult with your healthcare provider before making any changes to your health routine. Remember that you have the power. Join in next week to get more knowledge. Thank you guys for listening.
Thank you. It's so true. You have the power. Come get the knowledge.